This is our first fellow virtual tumor board of the 2024 academic year. It is Wednesday, August 7th, 2024. Congratulations to all of you who took the boards. I know it's a busy week and I appreciate you taking the time to be here. For us, this is really one of the highlights of our education curriculum, as we not only get a chance to talk as a group about interesting subjects, but also get to know each other a bit over the course of the year. I'm Mike Moore. I'm a head and neck surgeon at Indiana University in Indianapolis. We're very fortunate to have an expert group here today talking to us about the tricks and pearls of oral cancer management. Just a little background on these sessions, and I know you heard a little bit about them before. These are hour-long sessions. We try and stick fairly strictly to 20 minutes per case and do our best to get you out of here on time. They're going to be presented in a tumor board format, and then we'll pose questions to the experts that are in the audience here to get their comments and tricks. And then as attendees, feel free, and I'm going to man in the chat box here as well. Please enter any questions. I'm going to put it here into the chat. And then I'll try and bring them back to the group. I'll try and get to as many as I can, in the interest of time. So without further ado, thanks to the Mucosal section for organizing this. I know Ryan Jackson spent a lot of time in putting this together. He's away on personal time today, but let me see, is Natalia here yet? So Natalia AHNS is going to be one of our presenters from UT Southwestern. I can't tell if she's been able to join yet because I know she's probably finishing up clinical duties. Catherine Chang out of Emory University and Fahad Al-Hari out of University of Florida. Their faculty mentors, Baran Sumer at UT Southwestern, is going to try and call in. He's out of the country currently, but was going to hopefully be able to join us for part of the time pending his connectivity. Jen Gross at Emory University and Peter Ziegel-Lewski from the University of Florida. We affectionately call him Dr. DZ. Let me see. I don't know if Natalia has been able to join yet. So Fahad, why don't we kick it off with you to go ahead and present the first case.
All right. Good evening, everyone. It's an honor and a pleasure to be kicking off the virtual activities for this academic year. I'm Fahad Al-Hari. I'm the fellow at the University of Florida. The case that we'll be presenting today is around a patient that we saw not too long ago. She is a 30-year-old woman, a lifelong non-smoker, that presented to our clinic with a progressive tongue lesion for about 2 years. She was offered a biopsy by her local ENT in Panama City 2 years ago, but refused. And then she presented for an assessment secondary to progressive pain and intermittent tongue bleeding now 2 years later, referred by her local otolaryngologist. In terms of other head and neck symptoms, she had some dysphagia, odynophagia, and weight loss of about 20 pounds over the last few months of her symptoms. In terms of her risk factors, she had full body radiation at age of about 2 years for leukemia. She also had a bone marrow transplant around that time, but she has been in remission since. She's a never smoker, never drinker, and she has no previous head and neck cancers. And she presented to our clinic with no workup. So this is essentially what she presented with, a sort of a fungating exophytic lesion that was covering most of her visible oral tongue and reaching the junction of the ventral tongue with the floor mouth. In terms of her initial workup, we did a full head and neck assessment. There were no palpable adenopathies. We scoped her. The base of tongue and vallecula were clear. The lateral pharyngeal walls were clear. We also performed an initial incisional biopsy, and we got some head and neck imaging and metastatic workup going.
Fahad, just before we go on from there, How do you typically, maybe I'll start with Jen, when you see a patient like this in your office, obviously malignancy is high on the index of suspicion. So assessing somebody like that who's got obviously a very large, I imagine quite tender tumor, how would you assess its relationship to the mandible if it's too tender for them to really touch it much on the tongue itself? And then how do you get your tissue diagnosis for these patients?
You're asking me?
Yes.
Okay. I mean, I try and do as good of an exam as I can. Sometimes I'll spray them with some topical anesthetic to get a better exam, and assess the mobility from the mandible. Obviously, imaging is helpful with that. Obviously, if they have any kind of symptoms of V3 numbness, then that will tell me that there is involvement in the mandible. In terms of, sorry, in terms of how I would do a biopsy, I would also do, a very basic incisional biopsy of try and get a good piece of tissue, using probably just a scalpel and pickup. Were those your two questions?
It is. Yeah, no, I think I have a very similar approach. I would say the only other subtle thing that you can add, sometimes just pushing under the chin. If it's really painful for them in the mouth, you can actually see how much it wiggles from the mandible. If it's one that's kind of endophytic onto the floor mouth, and although not excellent, it gives you a little bit of appreciation for it. And yeah, incisional versus, a version of that, sometimes doing a punch biopsy. The 3 mm is nice because it's about the exact size of a silver nitrate Q-tip as well. But all right, Vod. So yeah, talk us through the rest of what you found.
Yeah, so her CT scan showed a 3.1 by 2.8 by 3 centimeter exophytic mass of the oral tongue, with possible involvement of the anterior floor of mouth, but there was no extension to the base of tongue again, no adenopathy. Her pathology came back as well-differentiated papillary squamous cell carcinoma. And again, this is in the context of a slowly progressive over 2 years sort of lesion, and her metastatic workup was negative. So, in terms of the treatment options, we offered the patient our usual treatment options for oral cavity squamous cell carcinoma. Essentially, on the top, we offered surgery followed by possible radiotherapy. We spoke to her about the possible extent of our resection, her need for neck dissection, and her reconstructive options. We also offered her primary chemo and radiotherapy. We offered her as an option chemo and oncology or immunotherapy, and obviously no intervention or palliation. She, after a thorough discussion,
Why don't we stop there just for a second, just to kind of get the thoughts of the group as well, and then we can maybe go through how you guys proceeded. So on the imaging, Peter, what imaging would you get for a patient like this with a pretty advanced oral tongue cancer? I guess more than anything to assess the extent of the primary, and why would you get that?
So for me, the typical imaging would be a CT neck and chest, or we call it here a CT max face neck. You need both of them to get the entire oral cavity. So to get that, if there's too much dental artifact and I can't tell the relationship of the tumor to the mandible, I'll get an MRI as well. In some cases, I'll also get a PET scan. I can't remember if we got one in this case, but in a case with something unusual like recurrence or someone with suspected aggressive pathology, I might get a PET scan right off the bat as well. But for most of them, it's CT neck and chest is what I'll start with.
All right. And Jen, you have similar approach to that as far as when you get a PET. Do you look for adenopathy before considering a PET, or?
We generally get PETs on everybody start, unless unless there is limited time, and or the schedule is too full for a PET scan, and then we can just get a neck chest, CT neck chest kind of faster. But we really try to get a PET on everyone to start.
And as you guys were presenting this, at your tumor board, did the history of leukemia and their prior therapy for that at all impact, or would it impact at your institution, the approach to treatment? And obviously there's no exact science to that. Sounds like, I would imagine, fairly low dose radiation for kind of whole body ablation. But also just your counseling with the patient on how the biology of the disease may behave in a patient whose status post prior kind of whole body ablative therapy, even if it was in the distant past. And you, Peter or Jen, either one.
Well, in our case up front, didn't really come into the treatment decision algorithm for this patient. Kind of kept it in the back of our mind. Discussing it with the patient, her having been a lifetime non-smoker, she's already had a previous cancer. We discussed with her that she probably has some kind of genetic defect that we don't know about, and this tumor may not behave like a usual one. That being said, she had it for 2 years, and it really hadn't spread anywhere, and it's just slowly growing. So we can't really predict exactly how things are going to go for her. She's young, so it's not a common age to get this type of cancer. So we had that discussion with the patient, but it didn't really factor much into the treatment decision, other than the fact she wanted the most aggressive treatment available, which for us was surgery followed by adjuvant treatment as needed. And then we haven't gone that far yet, but post-op, it did come in a little bit into the discussion, and we can mention that once we get there.
Sure. All right. Well, Fahad, why don't you walk us through how you guys approached it?
So when she opted obviously for surgery, after discussing all the options, we essentially explained to her that if she will require an ablative approach to the tongue with a wide resection, hopefully with negative margins. And then we discussed with her the need for neck dissection and reconstruction afterwards, both from a functional perspective and from a holistic treatment approach. The things that came up to mind when we were talking, thinking about her consent were, are we going to spare her base of tongue or not? Obviously, there wasn't any obvious involvement on the CT scan, and we also had in the back of our minds both pre-op and intra-op, whether we will need marginal mandibulectomy or not. She did not have any obvious disease that was close to the mandible upon assessment in the clinic, nor on the CT scan, and intraoperatively, we did not think that there was anything involving the mandible.
Which approach? Yeah. Oh, there you go. Yeah. So this is a great point. So what approach would you guys consider? Maybe I'll start with Jen, since Peter, I think this may have been your case. So why don't we get Dr. Gross's thoughts?
I actually have never found the need to do a mandibulotomy. I always try and do anything else. And especially in a patient like this, where you really I don't think need one for the approach. I would just make, a gingival incision intraorally and just drop the whole tongue into the neck to make the posterior cuts. So pull through.
Pull through. Yeah. And we didn't really mention this earlier, but I think just since this is one of the first sessions of the year, this patient would obviously need a thorough dental evaluation. High likelihood they may need some additional adjuvant therapy afterwards. These are going to be right in the high dose field for that. So if there are any teeth that need to be removed, especially if you're going to be doing, some sort of a lingual release or a pull through approach where you're going to be degloving the inner surface of the mandible, that's the time to get the teeth out of there, because you would then just overlay the sockets with your flap and when you do your reconstruction. Yeah, I would say I would certainly use a similar approach. The only caveat of times where I sometimes consider a mandibulotomy is if there's a lot of the floor of mouth musculature on one side that may give them some semblance of function, and you feel like that's your only chance to preserve that, just given how its growth pattern would threaten things like the contralateral lingual artery. Usually you can still do those just working above and below, but that's kind of one of the rare times if you're trying to really keep that mylohyoid and kind of the suprahyoid muscles on one side. It would give some semblance of, rather than just resuspending it, that can sometimes help. All right, why don't you talk us through that after the resection there?
All right. We obviously consider her for bilateral neck dissection. We did not involve level 4 as she was an N0 neck. And then we also spoke to her about reconstruction. So this was the extent of our resection. We were all the way back to the circumvallate papillae, but we did it through a pull-through approach, like a hemi pull-through approach. So we preserved the suprahyoid muscles on the left side, and only sacrificed them on the right side, the side of the pull-through. And this is essentially the defect that we ended up with intraoperatively. So that's the base of tongue at the very back, and essentially the floor of mouth along with the oral tongue were all removed. So the next question for us was, what are the goals of our reconstruction? Obviously, we wanted to separate the oral cavity from the neck. We want to create and maintain bulk for deglutition, for speech intelligibility, to try and prevent aspiration. And the famous question is, how do you try to get back sensation by doing any neurophies or nerve transfers? And then also the choice of reconstruction, as in terms of would you go for an ALT or rectus free flap, a thoracodorsal artery flap, radiform with a beaver tail, or a regional flap in that case.
Well, I see in our participant group here, Dr. Hoey, B. Hoey. I don't know if you can, if it's Dr. Hoey out of South Florida, if you can comment on your approach to reconstruction in this patient. I don't know if you're able to unmute. I don't know if he's available to comment. In the meantime, Dr. Gross, maybe you could comment on how you would approach it. Maybe first off, your choice of flap, and then whether or not you have any subtle tricks of the trade, and then whether you consider the nerve repair as well.
I try to get something that has sub-Q fat because I find that doesn't atrophy as much as muscle. So, especially in a female, I would say that an ALT would be my go-to option. You can also two-team, of course. I haven't done a rectus, so I can't really comment on that. But my thought is that the donor site morbidity is probably higher with a rectus than with an ALT. I also like getting the tensor fasciolata with the ALT for suspension reasons. I think regardless though of what you use, you're trying to get the bulk to get that tongue, that neo-tongue to touch the hard palate to help with swallowing and speech if they can do that. But all these flaps do end up atrophying over time. I try to suture the TFL to the cutaneous paddle to the gingiva to try and, suspend that tissue so it doesn't fall into the neck. But I wouldn't do a regional flap in a young person. I really try not to do pec flaps primarily unless I, really have to. And then a radioform generally just isn't enough bulk, I think.
Absolutely. Yeah, Dr. Zigolewski, your thought as well. I know you did this reconstruction, but if you can comment on it as far as your approach, any subtle ways you do to minimize, kind of help it bunch up for you in a way that doesn't compromise the perforator circulation to the flap, and your flap of choice for this?
I think flap of choice, first of all, I agree. I want something with a lot of sub-Q fat, ideally, and it's going to depend on the patient's body habitus. I mean, I've seen forearms that are as thick as ALTs, ALTs as thin as forearms. It depends on the patient. This young lady, she was somewhere around like 90 pounds, very, very tiny, very small BMI. Forearm definitely was completely out. Even her rectus was too thin. We looked at rectus versus ALT, and her ALT actually looked better than the rectus would have been in this case. So certainly want something with bulk. I usually measure it to overcorrect, kind of measure from one part of the defect. So like, let's say from one side of the teeth to the other with an arch that'll touch the palate to try to get a sense of some extra width on it. And then I don't have any really good tricks to get it to bunch up other than just travel along the flap more than I would around the teeth. It's pretty rare that you'd put too much in there and congest the flap or your perforators, but I have seen that happen before where I had to cut out a bunch of flap because it was too much. I think I've seen that once. Most of the other time, if it feels like it's too much and it's difficult to suture, you're probably doing it right, is what I tell our fellows. And then I like to use a TFL to suspend it. I do it on the under surface of the mandible by drilling little holes into the mandible and suturing through there. And Fahad will show you what we did. And yeah, those are the main things. If it's a huge defect and I'm taking some muscle as well, like with an ALT, I'll do a neuroraphy between the nerve to the vastus to the hypoglossal nerve to try to maintain some of the muscle to keep some bulk over time, even though a lot of it's still going to atrophy. But if you reinnervate it, it'll keep some bulk. Those are kind of the main things that I try to go for: overcorrection and some suspension. And if you can keep some of the suprahyoid muscles like we were able to in this case on one side, that's great. I think those would be the main things I would think of.
Absolutely. This is a great case. I think it highlights so many important points. I think it is important to remember, there were studies in years past to look at, and it was actually out of the WashU group that looked at using the latissimus free flap and reinnervating the thoracodorsal nerve to the hypoglossal nerve, and they would kind of put it crossways, and in a delayed fashion, you could see it kind of contract and although you could see some movement, it didn't actually, there was a question of whether it actually had significant benefit to swallowing. And so I think it's not been used as much for that. Spending a little bit more time here because I think there won a lot of great points. And I'm not sure if Natalia is going to be able to join us. We're still trying to reach her. So before we move on from this case, maybe one additional point. So for these subtotal, or maybe if this had extended back to involve the base of tongue, when do you consider doing just a total glossectomy versus including a laryngectomy? Obviously, for a young person, that's a very difficult conversation. Dr. Gross, do you have a cutoff? Do you offer a total glossectomy just by itself with necks and a reconstruction, or do you, some people I know have a philosophy of strongly considering an upfront laryngectomy in those patients?
I try and preserve the larynx at all costs, and even if a segment of the hyoid has to be resected, as long as the epiglottis is maintained, I will tell them, I'm going to try and save the larynx. And of course, I do warn them that there could be intractable aspiration if I'm getting kind of a little bit close, or I have to take even, some of the mucosa off of the epiglottis, for example. And we would, if that was the case, go back at a later date. Thanks.
No.
And Peter,
Sorry.
do you have a similar approach?
Yeah, I agree. I like to preserve the larynx if possible, pretty much at all costs. I think patients can do very well that way. But once you're starting to remove part of the supraglottic structure, like the epiglottis, then you're just creating a nice conduit for any food and liquid to just go straight down there. So once it's starting to involve resecting part of the supraglottic structures, then I would opt for a total laryngectomy. I agree. The hyoid doesn't play a huge role in it. You can still suspend the larynx through the thyroid cartilage if you want to do sutures to the mandible, so that can help. If the patients had radiation therapy, I would be much more quick to do a total laryngectomy because those patients already have a huge swallowing deficit, and they're probably going to be chronically aspirating. So in a patient who's had a full dose of radiation before, I would push probably more towards a total laryngectomy with a total ostectomy. But otherwise, I think it's a good option in most patients to preserve the larynx.
Sometimes for these patients, we will offer them, you know, a neoadjuvant chemo or immuno, just because obviously I don't think she would be a trial candidate, so it might just be chemo. But because if you're worried about a laryngectomy, that is, with the hopes of trying to spare the larynx, because in the end they're going to need a laryngectomy anyway. But I don't think that would be the case necessarily for this patient.
Yeah, I would agree that the end surgery, if it persists, you know, it's a rare instance you consider something like that, because especially without a lot of nodal disease, it's unlikely you're going to go from that to an incurable cancer, and the surgery would likely be similar. So there are certainly some patients who would balk at, you know, that, and would consider doing some sort of a non-surgical neoadjuvant. And it also gives you a sense on the biology of the disease, you know, as well. All right, well, why don't we transition to our next case? Dr. Chang, are you, maybe if you could stop sharing, we'll have Dr. Chang call hers up, and then.
Okay. Okay, can everyone see this?
Yep.
All right, perfect. Okay, so I'm going to be presenting management of very locally advanced oral cavity cancer for this talk. There we go. Okay. So we have a 47-year-old male. He's presenting with 5 months of left facial swelling and pain. To our clinic, he had progressive trismus and odynophagia and was mostly taking in liquids. He had a weight loss of 20 pounds, and then for the last 2 weeks, a numbness to the left lower face and chin. He was initially evaluated by a dentist and presumed to have a dental infection, have some mandibular molars removed, and treated with antibiotics without improvement. He was otherwise healthy, with a history of hypertension and asthma, and he was a never smoker and a never drinker. So on exam, he did have left facial swelling, pretty significant trismus to about 1 centimeter. The picture on the right is actually with a scope, sort of intraorally. He had this ulcerated endophytic mass to the left buccal cheek, extending to the retromolar trigon. It was then extending to the tonsil and lateral soft palate, onto the maxillary alveolar ridge and hard palate, and then onto the second and third mandibular molars. He also had tumor. The part that was extending onto the buccal cheek was near full thickness, although it wasn't involving the skin, and it was basically approaching the oral commissure.
All right.
He also did have
Go
left
ahead.
V3 numbness. He did have also left V3 numbness and a couple of palpable and mobile 1B and level 2 lymph nodes. His scope exam didn't show any extension of tumor to the posterior pharynx or vallecular or base of tongue, or to the nasopharynx.
All right. So,
my next slide is imaging, if you want to ask questions.
yeah, that's what I was going to say. Your guys' approach to imaging on this patient, and contrasting to the other one. Peter, maybe your thoughts first, and then Jen.
I think for this one, I would certainly do a CT max face, neck, and chest. This looks like it's probably going to be involving bone, most likely. I would also get an MRI to get a better sense of the bone involvement, as well as the soft tissue involvement through the pterygoids. Sometimes the MRI is going to show that a little bit better. Now, if it's possible to get a PET scan within a reasonable amount of time, I might do that instead of the CT chest. It's not always the case, since our patients are often traveling long distances, and sometimes getting the CT chest is just more practical. But that's where I would start.
All right. Jen, I don't know if you're available or not to comment on that.
I agree.
Yeah.
With all of that.
And you can see how, although it's very advanced in its presentation, it's not that easy to actually expose and visualize the tumor, I would imagine, at least based on the fact this is an endoscopic exam with the trismus and everything. So it's certainly one of those that can oftentimes come into your office fairly far along in their presentation. All right, so maybe we can see how the imaging looked here.
Yes. So the first thing we did was a CT neck. So I can play this on the left. But basically we're going to get to the infratemporal fossa masticator space, and there's a mass that's eroding through, involving the retromolar trigon and eroding through the pterygoid plates with clear involvement of the medial and lateral pterygoid muscles. It's also approaching kind of the coronoid attachment of the temporalis. And there's extension also onto the buccal space down here. So it's a pretty endophytic tumor. There's no clear cortical invasion of the mandible, but certainly obviously cortical invasion of the pterygoid plates and the posterior maxilla. And then on the right is just a snapshot of the tumor at the level of the pterygoid plates with erosion of the plates and then clear involvement of the pterygoid muscles. We also obtained an MRI on this patient, and this is a T1 with contrast given the lower lip, lower chin, and facial numbness. There was concern for mandibular nerve invasion. So this is a T1 with contrast, and we can see that tumor sort of redemonstrated. And then if you look in between sort of the lateral medial pterygoid muscles and follow it up, you can see that the mandibular nerve, there's thickening and inflammation of the mandibular nerve and enhancement, and it tracks all the way to the foramen. And then this is a coronal. You can see extensive sort of buccal edema and enhancement, and redemonstrated is the nerve as it goes into the skull base. So we were concerned, obviously, at this point that there was gross intraneural or perineural invasion to the level of the skull base. And we did end up getting a PET CT scan, like we do for many of our patients, but especially in someone with pretty concern for nodal disease, but such advanced oral cavity cancer. We did obtain a PET scan. It redemonstrates that tumor centered in the masticator space, and then some level 2 and level 1B nodes that are FDG avid. No distant, the scan doesn't show this, but there was no pulmonary or liver or any other distant metastatic disease on the PET. So the buccal biopsy was positive for invasive moderately differentiated squamous cell cancer. We tentatively staged this clinically as a T4B, N2B, M0. T4B, given there was invasion of the masticator space and the infratemporal fossa, the pterygoid plates, and also imaging and clinical evidence of perineural invasion to the skull base. And so management of this patient, our first initial questions were, which T4B tumors are considered resectable? We're sort of classically taught that T4B tumors are unresectable. But we know from practice that not all T4B tumors are the same, and that we do tend to offer definitive surgery to many patients. And if we do offer surgery, what is the goal of surgery? Is it truly that we think we can get an R0 resection versus, resecting macroscopic disease, knowing that we may leave some microscopic disease behind? And what is the goal in terms of, are we trying to truly improve survival or disease control in these patients? Or is this more of a palliative surgery, as these patients can be very difficult to palliate with non-surgical treatment? And then with regards to skull base management, how much skull base disease is too much for surgery? And then, later we'll sort of get into what the decision-making was at tumor board, but what is the role of, induction or neoadjuvant chemotherapy in patients who have very locally advanced oral cavity cancer?
Catherine, this is a very challenging case. Maybe we'll start with Peter on this one. What's your thought on discussions with a patient like this? Obviously young, sounds like fairly robust and healthy individual who has obviously a very advanced tumor. The likelihood of getting, well, maybe you can comment on whether you think that it's surgically resectable or not, and how you would approach this in your conversations with the patient.
Sure, I would be very realistic with the patient, starting off with discussing how extensive disease is and what the reality is of every treatment option. The survival rate is not going to be high no matter what we do, but if we do nothing or opt for non-surgical treatments, the outcome is going to be miserable. And as you mentioned, palliation through surgery might be the best option in any way you look at it. And then is surgery, is the goal of surgery and RZO resection possible? And I think it is possible in this case. I don't think you're going to get wide margins on this. That's, I think, probably quite impossible to do. But the best chance of this patient surviving with any decent outcome would be to start with surgery. So that's how I would look at it. But have a very frank discussion with the patient about exactly what that means and how big the surgery is going to be and what the recovery is going to be like, and the importance of recovering in a way that he can get to the next step of treatment, because surgery alone is not going to do it. He's obviously going to need adjuvant treatment as well.
What's your about the thoughts on the last line there, the consideration of neoadjuvant therapy in a patient like this? A lot of times it sounds great, but in practice, it's it's always a question of whether it has a role or not. And curious how it's managed at your institution. And obviously, I'd love to get Jen's thoughts as well.
Yeah, it's every now and then we get a patient who really wants to do something like that. And the reality is, in a situation like this, we don't have a lot of room for this tumor to get worse. So if we did neoadjuvant chemo or neoadjuvant immunotherapy and the tumor grew, the next place it's going to grow through is the skull base, or in the case the carotid, or or grow in any number of directions. So I think discussing that with the patient would be like, it's very risky that it could get much worse, and then we're not going to be left with any other option. On the other hand, there's a small chance it could get better, but I haven't seen that. I haven't seen this play out in a good way. I haven't seen it many times, but the times I've seen it, it's always gone south.
Dr. Gross, your thoughts?
If this was a T4A tumor, we have, some trial options for neoadjuvant immunotherapy. I think for chemotherapy, I agree with Peter. It's really all about having a frank discussion with the patient and the family and seeing, sometimes they feel one way versus another. I think one thing to note is that with the extent of disease and especially intraneural and just the size of it, I would expect there's a very high probability of positive margins with this surgical resection. I mean, it's not impossible to get R0, but so keeping that in mind, I think we do offer chemotherapy, induction chemotherapy in these cases, kind of depending on the medical oncologist because of that reason. And knowing that, regardless of what we offer them, they're not going to do well. So it's a very unfortunate kind of place to be in.
With regards to the skull base involvement here, it looks like it's primarily perineural invasion. It looked like obviously the pterygoid plates and the medial and lateral pterygoid muscles were involved, but as far as bone erosion, and maybe I missed it, it looked like it was primarily going up V3 through O'Valley into the lower, basically lower part of the trigeminal nerve. And so on those, if you're approaching them surgically, sometimes they have a little bit, you feel a little bit better about being able to at least more precisely address the area of concern. I think you recognize it's still going to be almost a certainty there's going to be some microscopic residual disease, at least in my practice. I've never seen one where there's a fat nerve on an MRI that's going through a skull base foramen that you can then get a very widely clear proximal margin that's negative. You may be able to, I guess the only one is sometimes the facial nerve, because you have a larger, area that you can resect of that. But, things like V3, you can sometimes go and find ovale and rotundum, remove the intervening bone, and that gives you a little bit more wiggle room to get up and resect more of the nerve. I'm curious to see in the next slides what was done here, but if you're going to approach this surgically, what sort of soft tissue approach would you do? And then for the diffuse, even with the absence of bone erosion on the mandible, how would you address kind of the diffuse pterygoid muscle involvement here, as far as that goes? Maybe I'll start with you, Peter.
And this is always a challenge, number one, to get to that area. And in a case like this, if I wanted, I would want big exposure, lots of comfort. I would split the lip and peel the face off laterally. We don't need a mandibulotomy because we're going to be taking bone anyway, so we're essentially making a mandibulotomy, and it's probably going to be a hemimandibulectomy in this case, all the way up to the TMJ. So it'd probably make the cut somewhere around maybe down the midline or parasymphysis, and then essentially you're creating a mandibulotomy that way. The other part is it looked like it may have been invading the posterior aspect of the maxilla. So I would make that maxillary cut posteriorly as well to kind of detach the pterygoids from there, and then work my way up towards the skull base. And in this case, I may even remove the zygoma and potentially replace it later, plate it back together to get into the infratemporal fossa. But I'd want to get all along the sphenoid bone and the skull base as much as possible, to get all the pterygoids and their attachments out as much as we can. That's our best chance for, I think, getting a R0 resection, even though we know there's a good chance we're going to be leaving some microscopic disease behind somewhere. And then as I do that, I expect lots of bleeding from the pterygoid plexus. So keep my bipolar up really high, like at 80, use other energy devices like a ligature or harmonic scalpel, crank the bovie up pretty high, and just work my way around that, with the idea being that I want to clear everything off that skull base out of the infratemporal fossa.
Jen, do you have any additional thoughts on how you tackle it? These tumors extending to the pterygoid muscles?
Yeah, so I think that I've been able to, obviously totally case dependent, do a segmental mandible where you just remove the coronoid, like the anterior mandible, so you don't have to plate or recon the bone. And then by removing the anterior segment of the mandible there, you can then get access to like the lateral pterygoid origin at the condyle and kind of go all the way to the condylar head if you need to. You can get the entire pterygoid muscles. It also helps to get the pterygoid plates. This patient in particular did have cutaneous involvement, so it made it would make that part a lot easier for access as well. But generally for these patients, it will require some radical parotidectomy just because of the proximity to the parotid, and just a multi directional approach. If you don't have the cutaneous involvement, obviously you have to go transoral, transcervical. I mentioned I don't like doing a mandibulotomy if I don't have to. So with this patient, I would, if there wasn't the cutaneous involvement, extend the incision kind of like a parotid and lift the skin as high as possible to get access because of the trismus, and just kind of go from all angles to get what I need to do.
And I think one of the things that's a challenge when things get into the pterygoids is there's so little resistance for tumor spread. And, I think when instances like that happen, it's sometimes, at least I've found, it's helpful. Think of the muscle going to attach its attachments, and depending on the morbidity it would impart, you sometimes need to actually take those areas out en bloc. So here, if it's extending to the pterygoid plates, you have to take those out. Depending on how lateral the tumor extension is, it's to the mandible, right at the retromolar trigone. It would be a little tricky to save the posterior ramus, but possibly you could. I think I'd have to look at the image again. But sometimes then if you unblock or removing the ramus as part of the resection, then it helps to just think about what is it. It's always tight to deliver that down. So what are your attachments? So you can detach the condyle of the mandible. You can obviously detach the temporalis muscle attachments. You got the sphenomandibular and the stylomandibular ligaments down below. And then a lot of times, mainly what you're set on, if you've made your pterygoid plate cuts, that's usually an attachment as well. You take your distal and your proximal, ECA branches, and then as Peter mentioned, obviously there's always bleeding either in the pterygoid plexus or in those distal kind of terminal branches off the external carotid going up to spinosum with the middle meningeal. You'll want to address also coming right back behind the mandible, the auriculotemporal nerve. But sometimes that and the lingual nerve can kind of help guide you towards where that's going up to ovale, because they're both going to join V3 near the skull base. And that's usually your last attachment. So you've detached all these other ones because they're easier to address on the way in. And then it's that last kind of battle to be able to dissect down. And Peter mentioned a great approach, sometimes going from up above, either taking down the zygoma and peeling down the temporalis muscle, or if you come at it from below and are able to move the facial nerve branches out of the way and still get access and divide through some of the temporalis, you can get, to the skull base and then, dissect down, and looking back kind of back behind where those kind of lateral pterygoid plates extend, you can see ovale there and address it almost from up above where the tumor is. These are hard though, because it's always a challenge. You never, unless you kind of take those wider approaches, you never really feel like you get a legitimate margin when they get into the kind of these muscular beds like this. Well, Catherine, you want to take us through the rest of the case here?
Okay, so we discussed this patient at our tumor board, and we essentially offered two treatment options. One was induction TPF followed by surgery and adjuvant chemoradiation versus surgery and adjuvant chemoradiation. And we did have our frank discussion that obtaining negative surgical margins would be difficult, and that his prognosis was fairly poor, especially given the perineural invasion either way. And there was a discussion of proton therapy as an adjuvant treatment for the perineural skull base disease. And ultimately, the patient chose option 2. And we did discuss that with induction, chemotherapy, there was no guarantee at all that he would have any regression of disease. But certainly there was potential that he would have progression of disease, and he didn't have a lot of space to go there. So the patient underwent surgery, which was a subtotal maxillectomy, sparing the orbital floor with an infratemporal fossa resection. Because the tumor in the buccal space approached the skin, we did start with just sort of a wide local excision of the cheek, full thickness, and we were able to access the mandible and connect that with our neck incision. We did do a segmental or marginal mandibulectomy of just the ramus and took the coronoid and released the temporalis muscle, which gave us a little more mouth opening. And we did release the masseter, and we were able to make some of those cuts through the external facial incision. And then we were able to get enough mouth opening after doing those maneuvers to do some of this intraorally as well. We then did a bilateral neck dissection and reconstructed with a fibula-free flap. We ended up taking the hard palate basically to the canine and did a subtotal maxillectomy, resected the pterygoid plates, and then we followed, we resected basically the entirety of the masticator muscles with the exception of the temporalis that was sitting in the temporalis fossa, temporal fossa. Of note, so the maxillary mandibular nerve did have positive margins intraoperatively, and so those nerves were followed back to their respective foramen and were drilled down actually to obtain additional margins, which were set for permanent. We did note, unfortunately, gross disease in the foramen ovale. And then initially in our resection specimen, we had 2 margins that had microscopic disease, the infratemporal fossa muscles kind of superiorly, and then also the posterior pharyngeal margin. We had to take our cuts kind of almost to the lateral soft palate. Those were actually positive, and we had to resect twice, and we ended up sending them both for just permanence on final. And this is just a picture of the resection. You can see sort of extended all the way to, we actually ended up having to take part of the commissure. You could see the buccal space, and then sort of the maxillectomy, and then posteriorly you can see the pterygoid muscles that we had to take, and then on the superior aspect is the hard palate and the nasal floor, and then the bottom right shows kind of a superior view of that specimen and the sort of extraoral resection that we had to do. So final pathology, this was a really large 7.7 centimeter tumor with a depth of invasion of 23 millimeters with LVI and gross PNI. The final specimen margins did end up being negative. We were able to clear the infratemporal fossa and pharyngeal margins, but again, they were resected twice due to microscopic disease on frozen. And then the final on the mandibular and maxillary nerve were positive for carcinoma with intraneural involvement with the mandibular nerve. And then 4 of the 31 lymph nodes were positive with major E&E. And so sort of my last set of questions, obviously we discussed that this patient would certainly need chemoradiation. We discussed that option with it up front, given just how aggressive locally the cancer was. And then sort of what our other thoughts about this case were, management of skull base disease in the setting of perineural invasion. And so initially on the scan, we didn't see sort of the gross tumor kind of going up to the level of the skull base. It was mostly tracking along the mandibular nerve. And so how far do you chase PNI into the skull base? And what is the role of adjuvant proton therapy in patients with gross perineural invasion, especially if you are unable to clear that margin? And then the last question is like kind of a loaded question, but how far do you chase a positive margin in a patient like this? How much benefit are they really getting in this setting?
Well, this is a great case, Dr. Chang, and thank you so much for putting it together and really amazing surgery. I'll comment briefly. Actually, I know Natalia has been able to join us, so I do want to give her a little time to present here in a moment. So maybe we could just go briefly through this. I know my mentor at one point when I was in training always said, your closest margin is your closest margin. So at least my take on chasing margins is if you feel like without a lot of additional morbidity, you're going to actually improve their margin status, I consider doing it. But if it's something where you already have a known positive margin, how much you're going to go chasing after other ones, especially if you're imparting a lot of additional morbidity, is something that I typically would shy away from, just depending, because at that point you're really dependent on the biology of the disease, whether it's going to respond to this adjuvant therapy or not. Certainly with proximal nerve involvement near the skull base, would consider protons if available here. But at the same time, I think IMRT can also offer it. One question came up from the audience I'd love to briefly get. Maybe I'll have Jen comment on this just because she was involved in the case. Commenting on the approach to reconstruction, this was sounds like accomplished with a fibula. I don't know if there was an additional soft tissue flap on top of that. It sounds like the fibula was used more for maxillary reconstruction since you did a marginal mandibulectomy and left the lower ramus of the mandible. Was there additional soft tissue component or just a massive fibula skin paddle?
So I'm actually on maternity leave, so I did not do this case. I haven't even seen Catherine in person yet. Catherine, do you want to comment? My guess is the fibula was for the maxilla, though.
Yes. So we did a 1-segment fibula to reconstruct the maxilla, and we did use a very massive fibula skin paddle. Initially, we were going to try to do like a chimeric skin paddle because we did find a proximal and a distal perforator, but we used like SPY fluorescence and actually saw that this like huge, like 15, 16 centimeter skin paddle was supplied by that one perforator. And we just de-upped it and sort of folded it to reconstruct the intraoral component. And then at the commissure was sort of where the de-upped portion, we sutured it sort of to the mucosal, I guess, lip or mucosal lip. And then the external paddle was then just to reconstruct the face.
So just because this is such an interesting reconstructive challenge, Peter, your approach to that one, how would you have tackled it? It sounds like a fairly, subtotal maxillectomy, a large soft tissue void that's there, but the mandible itself has continuity in it.
The way I would think about this is a couple of things that don't always come to mind. Number one would be the infratemporal fossa. You're going to leave a big dead space in there if you don't fill it with something. You have some facial skin, and then you have some mid-face as well to reconstruct. So I would think I need some bulk. A little bit of bone would be good. You could do this whole thing with soft tissue. I mean, you could say this prognosis is terrible. Let's do the quickest possible flap just to have a safe wound and get the patient off the table. I think that would be perfectly reasonable. You could do a big rectus, ALT, or latissimus. But if you wanted to achieve all the goals, I think a scap tip with a pedicled lat with skin, like not necessarily a Tdap, but latissimus with skin would be good. And you can also take some serratus anterior if you need to fill in that infratemporal fossa, so you don't get this big hollowed, sunken in look after the patient gets adjuvant treatment. That'd probably be my first choice. But if this patient wasn't in the best of health and we needed to get him off the table sooner, I might say let's do something that we can do a little quicker in a two-team manner, and maybe just soft tissue, a big ALT or a rectus flap.
Yeah, I think that's a great point. And Catherine, maybe I'll have you stop sharing just so we can be getting Natalia's slides loaded up. While we're making a transition, the comment on the infratemporal fossa dead space is a critical one, because you're going to basically clear off the entire skull base and then radiate it. So getting some sort of soft tissue bulk in there to fill that, because if it starts to fall down, there's no way to get it back up there. And so, not only getting something in, but trying to tack it up in a way that it's favored to swell and almost push against that bone really gives the best chance of it kind of sealing in. Occasionally you can get these little kind of potential spaces in there that become a big hassle down the road because they're virtually impossible to repair. Natalia AHNS, I appreciate very much you joining us. I know sounds like you've had a busy day, so thank you for being nimble and being here out of UT Southwestern. Welcome to fellowship. I'm glad to have you a part of the session. We're a little late on time, but I think we'll still be able to get through this case. We may just abbreviate it a little more than some, but we'll probably just spill over a little bit past the normal time. So yeah, if you will, why don't you take it away?
Oh yeah, thank you for having me. I apologize. We were just in a less than opportune moment to leave earlier. So
no worries at all. We understand.
Yeah, and I think this case shouldn't take too long. I think it's kind of a good clinical topic, not particularly complex from like a surgical or recon standpoint. So, all right, here we go. So this is an 18-year-old female. Initially, when she presented, she had a tongue lesion for 3 months. An outside hospital otolaryngologist kind of resected it and had found that there was squamous cell carcinoma and had referred her over to Dr. Tumor. Her past medical history is significant for beta minosidase deficiency, which is essentially a lysosomal storage disease, kind of affects how you process sugars. It's not found to be related to squamous cell carcinoma, kind of presents with hypotonia, some intellectual disability, amongst some kind of ovarian issues. Non-smoker, non-drinker, and nothing particular about her social history otherwise either. On her physical exam, this is her physical exam when she had initially presented to the outside ENT, 1.4 centimeters, right ventrolateral tongue lesion, sparing the floor of mouth, no cervical embeddinopathy, and her scope was normal. When she came to us, she had a kind of just granulation tissue evidence of where this excision occurred. CT, neck, and PET at that time. This is from 2011, so unfortunately I didn't have access to the images for this, but it was misread as tongue base. It really was the oral tongue, and had corresponding FDG avidity in that area, otherwise unremarkable. So her initial biopsy from that outside was well-differentiated squamous cell carcinoma, arising in a papilloma, P16 negative, and the excision margins were 0.2 millimeters. She was consulted on re-resection with wide margins, knowing that, the final pathology may not reveal carcinoma. That was done, and so she had a partial glossectomy. That pathology revealed squamous mucosa with focal mouth dysplasia. Margins were negative for both dysplasia and carcinoma. The decision was also made to perform a right neck dissection, levels 1 through 4, selective neck dissection. There were 0 out of 19 lymph nodes that were positive. The reason for that was based on the description of how the lesion initially looked and the size, and in order to try to avoid any kind of radiation therapy. That's kind of the thought process behind the neck dissection at that
Natalia,
time.
can I just ask a quick question? So
Sure.
to Peter, when do you consider doing, so say you have a fairly, an oral lesion, doesn't feel overly deep. And your question whether it was just a surface lesion or a truly invasive. When do you make the cutoff for when you do an upfront neck dissection versus not? And do you ever base that on frozen section or wait for permanent pathology?
Good question. So I start off doing a punch biopsy in clinic, like you were mentioning earlier, and I try to get something that hubs the punch so I can get a good sense of the thickness. So I'll start with that. If that can give me a definitive answer, then I can make the call up front. And I like to use 2 millimeters as a cutoff. Anything more than 2, that's my cutoff for recommending a neck dissection in most oral cavity cancers. And if I don't have the depth of invasion on the biopsy, then I discuss the option with the patient and tell them, we could do a neck dissection up front. It might be overkill, or we can do it in a staged fashion. Cut it out, wait for the final, the final pathology, and then come back and do the neck dissection after. I've talked to our pathologists, and they haven't been able to tell me that they can do a reliable depth of invasion on frozen sections. So they've always said what they prefer to do final pathology. So I would stage it if that's what the patient preferred to do.
Excellent. Thank you.
Okay. All right. So moving on a few years, in 2014 now, she had a recurrence of a suspicious lesion. She underwent a biopsy in the operating room, a direct laryngoscopy with biopsies of the base of tongue as well as the oral tongue. That revealed carcinoma in situ and suspicious for invasion, and so then was recommended to have a partial glossectomy. Same site, that final pathology revealed carcinoma in situ.
Quick question, I guess, before we go from there. On the invasive disease, Dr. Gross, how do you assess the margins at the time of surgery for those who have partial glossectomy for an invasive, like lateral tongue cancer, for example?
You mean with frozen section?
Right. Yeah. Do you do it as a specimen-based or a wound bed?
Oh, specimen based. I mean, I think there's enough literature out there showing that the outcomes are better and the risk of having to do a re-resection is lower. And then of course, if you're doing tumor bed based margins and it's positive, the likelihood of getting to that same spot to re-resect is pretty low. I can't remember what percent it is, but it's pretty low. So at Emory, at least, we do it all tumor-based margins. We walk it over to the pathologist and review it. And if I have any questions at all, we'll actually stay there and cut it with the pathologist so I can see exactly where the closest margin is, re-resect if needed. But hopefully you get it right on the first go around.
Peter, you have a similar approach?
Yeah, the way I do it is before cutting out the tumor, I kind of map out where my resection is going to be. And so I take a ruler. I like to do 2 centimeter surgical margins. So I measure out 2 centimeters all the way around. And then I take circumferential margins all the way around my planned resection, then do the resection, then take the deepest margin off right before we remove the entire tumor, knowing that that's probably the least reliable of all the margins. I think the superficial mucosal ones are the most reliable and the easiest to re-excise if you have to. But I agree with Jen. It's that deep one, that the chance of you getting right back to where it was is pretty low. And then I do think that taking the specimen to the pathologist is key, not only for assessing, potentially close margins that you can re-excise, but also for orienting the specimen for analysis afterwards. Many times they don't always understand the 3-dimensional anatomy. So if you can show it to them, draw a picture, help them ink it, it can make a big difference in your pathology reporting.
Great question came up from Fahad on the role of sentinel node biopsy in this original one. Do you ever consider doing that for early oral cancers that are clinically in 0? Either Jen or Peter, either one of you have experience in that.
Yeah, I mean, we participate in the AHN006 trial. So we actually are only offering sentinel node trials for oral cavity if they're, sorry, sentinel node, lymph node biopsies for oral cavity if they're on that trial. I think we tend to err on the side of neck dissection, especially if it's oral tongue, just because, they can be very aggressive. They can come back, even if it looks like it might be really superficial. It might be more, have more depth than you initially think. So we tend to just do a neck dissection on most patients unless they are not a good surgical candidate, or they really, really, insist, or if they are interested in the AHN006 trial and get randomized into the sentinel lymph node arm.
Sounds good. Yeah. And just remember, we do have level 1 evidence to show that you need to manage the neck somehow once it's above 3 millimeters deep. And some people certainly use a little lower cutoff from the DeCruz study, comparing observation with close surveillance and therapeutic dissection if they develop nodes versus an upfront elective neck dissection. They showed a significant survival advantage when they did the upfront dissection, but that's what this AHN006 is designed to look at. Well, would the sentinel node offer a similar benefit by kind of stratifying which one of those need the formal dissection by testing the most at-risk nodes? So very good. Natalia, you want to continue on?
All right, so similarly, a couple years later in 2016, she had another recurrence of the lesion, had a partial gastrectomy, and that showed carcinoma in situ once again. Couple benign biopsies in 2017, followed by another partial gastrectomy. This is probably the one that we have the most information from. Here she had final pathology showing a well-differentiated squamous cell carcinoma, 0.2 centimeters in size. Depth of invasion was 0.5 millimeters. No lymphovascular invasion, no perineural invasion. And then the closest margin was 2.5 millimeters away, and that was the deep margin. She then continued follow-up. Again, another lesion. She had no adjuvant treatment at that time. She had another recurrence of a lesion in 2021, had that resected with partial gloss, moderate to severe dysplasia on that, with severe dysplasia 1 millimeter away from the lateral margin. And then finally, another lesion this year in April, for which she went another partial glossectomy, and that was benign. So here's like a just summary kind of her treatment history that we just reviewed. So she was diagnosed at 18, she's now 32. Her staging as follows with T1 and 0, 2011 recurrence, T1 in 2018, with that summary of pathology right there that I just discussed, and kind of her entire history right there with the surgeries that she had.
So this is obviously one of the most challenging scenarios, and I'm glad I'm on this session because I'm hoping that you guys all tell me how to manage these people, because they are very, very difficult. I certainly have not found a great way. Peter, maybe I'll start with you. These patients with just kind of multifocal, this one seems like it's centered a bit more in one area, the right tongue, but certainly there are ones where it's like, proliferative verrucous leukoplakia, or lichen planus, where it's just popping up everywhere as dysplasia or precancer, or sometimes early invasive disease. How do you manage those? Your surveillance regimen, do you have any other non-surgical approaches that you use, like topical agents or other chemopreventive agents that you believe in?
A great question. I think, just like you said, these are very challenging patients. I've got a number of these in my practice. For surveillance, they're usually very in tune. And so I tell them, we're going to see you every 3 months or so. Anytime you notice something new, call the office and I'll see you right away. And anytime they find something new, they're typically in there pretty quickly. And eventually from my experience, they'll end up with something that needs a much bigger surgery. I had one recently that eventually ended up needing a mandibulectomy with these multiply recurrent areas. Some of the other ones, I tried to convince one of our medical oncologists to just give immunotherapy to them to see if this would help, because we had nothing else to offer. And we came up with a compromise. We had, I don't know if you guys are using any of the circulating tumor DNA tests, but there's one Signatera that we've been using. And so we decided, let's do that. And if it comes back positive, maybe we can convince the insurance company to pay for some rounds of Keytruda. Luckily, it was negative, but that was kind of our thinking about something we might be able to offer these patients, that if they still have circulating tumor DNA after their latest resection, perhaps we can add in some immunotherapy as sort of a treatment / preventative measure. But I don't have the answer to these, unfortunately.
Any topical agents or any other tricks of the trade, Dr. Gross?
Yeah, I mean, these are very challenging. I think there aren't great chemo preventative options for this problem. We have a trial for active or previous smokers who can take metformin as a chemo prevention if they have any type of dysplasia. And there is some data from a phase 2 trial showing that in these patients, there is a greater likelihood that the dysplasia resolves. So, I mean, if they aren't a smoker, I don't really have a good option for them. And kind of like what Peter said, unfortunately, in my few years of practice, have seen that these often progress to larger cancers, and you just have to keep a very close eye on them. So preserving the radiation for the large cancer is kind of what we tend to do.
Yeah, I agree. I think one of the most tricky situations is people kind of overreact to a close margin or dysplasia or something and try and then throw like radiation or some other adjuvant therapy at it. And like you said, you almost want to save that for a later time. I have heard of a clinical trial of using topical 5-FU, which is similar to what you use in early skin cancers, but not for invasive disease, for precancers. There's a place out of Ohio. It's actually not an academic, it's a private practice group, but I've had a couple patients who've interacted with, and actually so far I've been very impressed with the patients I've sent over there. And I think there actually may be one for ones where they have multifocal invasive disease. I believe there's an ongoing clinical trial that actually does use immunotherapy for that. I think for the similar reasons, but since it's done on trial, I think they were able to get it passed. But obviously, it's a very challenging situation. One question from the audience came in. I think that leads to your next slide, Natalia. Is was Fanconi's anemia ruled out, or what other testing was done?
Yeah, so she did formally see the genetics team over here, and they just clinically kind of determined her risk factors and whatnot, and didn't do any formal genetic testing, but they decided that she had a low likelihood for Fanconi anemia. Actually, she declined further genetic testing, I should say. Her surveillance with us has been kind of similar to what others have said, about every 3 months or so. She has been coming in over the course of these years. She had, aside from the initial CT and PET, she had like two other CT necks and 2 other PET scans. And then other than that, her main surveillance imaging modality has been a neck ultrasound. And yeah, that's no other kind of adjuvant treatments or adjuvant therapies or testing besides that.
All right. Well, these are all 3 very different but very challenging and thought-provoking questions and cases. And thank you guys all so much for putting them together. Obviously, there I think are a lot of other points that we could talk about here, but just in the interest of time, I want to probably wrap the session up. But thank you all so much. So Natalia AHNS at UT Southwestern, Catherine Chang at Emory, Fahad Al-Hari at University of Florida, Jen Gross at Emory University, and Peter Dieselowski, sorry. Thank you all so much. It's really a great session. The next one will be held on Wednesday, September 4th. Again, 7 p.m. Eastern time. That's going to be on soft tissue reconstructions of all different shapes and sizes. It's going to be hosted by the reconstructive section. So thanks so much. Look forward to seeing y'all then. Appreciate all the speakers' time.
Thanks so much, everyone. Have a good night.
Thank you.
Thank you.
Thank you.